Hi students. On this recording, what we're going to be talking about is the difference between an action potential in a neuron, which we see diagrammed on this graph in green, and an action potential of a cardiac muscle cell, which is diagrammed in red. Now, if we look at both of these action potentials, they begin with what we would call the resting membrane potential. You all are familiar with resting membrane potential and know that it's caused by several factors, including the fact that sodium ions are present in much higher concentrations on the outside of the membrane than on the inside of the cell's membrane, and potassium is present in the opposite concentrations, much higher on the inside than on the outside, and several factors maintain that condition. However, at the initiation of an action potential, we have the sudden opening of gates on sodium ion channels. The sudden opening of those gates allows sodium to rush down its electrochemical gradient and enter the cell. The movement of the sodium ions with their positive charge depolarizes the membrane, moving it to and actually even slightly beyond zero. The sodium gates are only open for a short period of time, and as they close, we reach the peak of the depolarization. This is followed in green on the neuron by a very rapid repolarization phase, as you're familiar with, but in the cardiac muscle, we see a repolarization that's much, much slower, and it actually begins with what we call a plateau phase. This plateau phase is caused by a condition that doesn't take place at all in the neuron. The plateau phase is induced when gates for calcium ion channels open. Now, calcium is present at rest in higher concentrations on the outside of the membrane as compared to the inside. So when the calcium gates open, calcium rushes into the cell, and it's that influx of calcium that maintains the plateau stage for an extended period of time. The calcium gates also close, and as the calcium gates are closing, the potassium gates are becoming fully open. Now, the opening of the potassium gates allows potassium to flow down its concentration gradient, which will be from the inside of the cell to the outside. The movement of the potassium ions then reestablishes the resting condition. This is the same as what we saw in the neuron that we studied last semester. Now, if you look at this part of the tracing, what we see is a period of time that we call the refractory period. The refractory period is significant because during this period of time, it is impossible, if not, or at least very difficult, to initiate a second action potential. The refractory period has a portion that's called the absolute refractory period, during which another stimulus, no matter how strong, cannot initiate a second contraction. The relative refractory period is a period of time where it takes a much stronger stimulus than normal to initiate a second action potential. Now, why would we have a refractory period? This is obvious when you think about the entire reason for the action potential in the cardiac muscle cell. This triggers contraction of the heart. Contraction of the heart has as its purpose the pushing of blood out of the heart and throughout circulation. In order for this to be effective, there has to be a period of time during which blood can flow back into the heart while the heart is relaxed, so the heart can be refilled with a fresh load of blood that it will then pump out with the next contraction. On this slide, we're looking at some diagrams that illustrate the electrocardiogram, an ECG, sometimes also called an EKG. Now, if you look down the right-hand side of the page, you see some tracings that you may be familiar with. If you've had an ECG conducted in a clinical setting, hopefully you came out with a tracing that looks like this one that represents a normal heartbeat. In this tracing, we have peaks, large and small, and they're separated by regular intervals of distance representing regular intervals of time. If your heartbeat is unusually fast or unusually slow, that is reflected in a shorter or a longer distance between corresponding peaks. An irregular heartbeat would show up with some short distances and some longer distances between the peaks. Okay, so what's going on here? What exactly is an electrocardiogram? Okay, now in order to conduct the electrocardiogram, electrodes are placed on the patient's body in different places and they pick up the wave of electrical current that's passing through the cardiac muscle tissue. Basically, there are three components to an ECG: a P wave, a QRS complex, and a T wave. The first part, the P wave, corresponds to the period of time during which the atria are depolarizing. This is initiated by spontaneous depolarization of the sinoatrial node, also known as the pacemaker of the heart. Depolarization initiated at the sinoatrial node is spread by way of gap junctions from one cardiac muscle cell to the next, all the way across the atria, and that gives us our curve, the P wave. The QRS complex is initiated when this wave of depolarization is picked up at the AV node, atrioventricular node, and spread from there down the bundle of His into the ventricles, through the interventricular septum by way of the bundle branches, and then through the outer wall of the heart by way of the Purkinje fibers. This is a strong and powerful depolarization of the ventricles, so we'll represent that here, ventricular depolarization. That's followed by a stage that could be called a recovery wave, and this is the ventricular repolarization phase as membrane potential goes back to resting conditions. Okay, so we've got atrial depolarization, we've got ventricular depolarization, and we have ventricular repolarization. Does it look like there's something missing? It does. If the ventricles need to repolarize, shouldn't the atria repolarize too? Well, the truth is that they do. The atria repolarize during the same interval of time as the ventricles are depolarizing. Because the ventricles are a much greater mass of tissue, the electrical activity involved in ventricular depolarization is much greater, much more powerful, you could say, than the electrical activity of atrial repolarization. And so this atrial repolarization is masked by ventricular depolarization. The cardiac cycle is a term that we use to describe actually several different events that are taking place simultaneously as the heart is undergoing each heartbeat. These different activities are very closely interrelated and each induces the others. The first cyclic activity of the cardiac cycle would be the ECG, or an electrocardiogram, as an electrical wave is passed across the heart, and this is something that we described on the previous slide. Now, the electrical wave is followed by a wave of contraction. The contraction of a heart chamber induces greater pressure on the inside of the chamber. Relaxation reduces the pressure on the inside of the chamber. This pressure has two effects. One effect is, as pressure builds in a heart chamber, it will force the opening of the heart valve that leads from that chamber to the next. As a ventricle builds up in pressure, then not only will it open a heart valve leading from the ventricle into the blood vessel that follows it, either the pulmonary trunk or the aorta, it also will force closure of the preceding valve, which would be the atrioventricular valve, so that blood cannot flow backwards from the ventricle back up into the atrium. Now, the pressure changes induce the opening and closing of the heart valves because it's pushing the blood that it contains forward. So, a chamber fills during a period of relaxation, and a chamber empties during a period of contraction. This cyclical activity is also responsible for the heart sounds that may be heard by a stethoscope. Specifically, the heart sounds are induced by opening and closing of heart valves. This is a really complicated looking diagram, but it shows a whole lot of different events that are taking place during the cardiac cycle. Because they all influence one another, it's important to see in a graph like this what exactly is going on when and how they interrelate with one another. Okay, so if we start by focusing on this red line right here, I can make my arrow red. That represents the pressure in a ventricle. We'll say this is specifically the pressure in the left ventricle. And then this blue line right here, which represents the volume of blood, how much blood is contained within that ventricle during the different stages of the cardiac cycle. We'll just look at how they relate to one another and how they influence the opening and the closing of the aortic valve, the aortic semilunar valve, and the opening and closing of the AV valve, which would be, in the case of the left atrium and ventricle, the mitral valve. Okay, so if we start over here on the left of the diagram, we see a period of time during which the volume of blood contained within the left ventricle is increasing. This increase in blood volume is caused because at this point in time the valve between the atrium above and the ventricle is open. As long as the valve is open, blood flowing into the atrium through the inferior and superior vena cava can flow right on through the atrium down into the ventricle. Okay? As the volume of blood in the ventricle increases, it reaches a period of time during which it generates enough pressure that the AV valve will close. Once the AV valve closes and contraction of the ventricle is initiated, then pressure builds very, very rapidly. As this pressure builds to a certain critical level, it's great enough that the semilunar valve leading into the aorta is pushed open. When that valve opens, then blood can leave the ventricle and go into the aorta and out throughout systemic circulation. So that's why we see the volume decreasing in this phase. Contraction reaches a peak, and then it begins to diminish as the heart muscle relaxes. It will diminish to a point at which the pressure is low enough that the aortic valve closes and no more blood is pushed out into systemic circulation. The relaxation of the ventricle continues, and when pressure inside the ventricle is lower than pressure in the atrium, then the AV valve will open up and blood will once again begin to refill the ventricle as it flows from the atrium through the open AV valve. And then here, what we have in this part of the diagram is a repeat of what we already described earlier. As the pressure builds, the AV valve closes, contraction is initiated, the aortic valve opens and blood flows into aortic circulation, and so on and so forth. Okay? If we look down here where the electrocardiogram is superimposed on this diagram, we can see that during the period of time of the QRS complex, it is followed very rapidly by contraction. So the action potential initiates the contraction as you would exactly expect. This tracing up here, the dotted line that we see that represents the aortic pressure, you can see that the fluctuations in aortic pressure correspond to the times when the aortic valve is open and blood is flowing into the aorta. If we look here at the other dotted line that represents atrial pressure, we see very little change in volume. It does increase and decrease as the AV valve closes and then opens up again, but the atria are low pressure vessels, and most of the time the AV valve is open and blood flows through the atrium right on down into the ventricle. Down at the bottom of this diagram, the phonocardiogram represents the intervals where heart sounds can be heard. Okay? The first heart sound, we describe it as lub, because that's what it sounds like. Lub. The lub corresponds to the closure of the AV valves. The second heart sound is usually called dup. this dup sound, this sharper, quicker sound, comes from the closure of the aortic, the semilunar valves. Okay? So the lub-dup is closure of the AV valve followed by closure of the aortic valve.